Hello, everyone, and thank you for joining us for the latest segment of our hospital community benefit webinar series. My name is Brian Lane, and I'm the President and CEO for the Center for Health Affairs. And for those of you who joined us for the first time, this is our second episode in our three-part series on hospital community benefits in Northeast Ohio. And during our first episode, the Center's own Lisa Anderson and Bob Kalashevsky provided an extensive overview of what community benefits are, the importance of community benefits, the impact of community benefits, as a whole within our region. And that episode is still available to watch anytime on Bright Talk channel, which you're on right now. And those of you that did not get a chance to actually view it, please, partake. And Bright Talk, for everybody's edification, is the world leader within the B2B space and as our global strategic partner for our virtual events as well as our leadership education series. Now on to today's session and event, which I'm really excited about. When we look at a person's health and well-being holistically, we've noticed that as much as 80% of a patient's well-being is due to factors outside of the hospital's walls. This means that medical determinants of health are only one part of a person's health and well-being. Non-medical determinants of health, known as social determinants, are the main or many factors impacting people's lives, where they live, where they learn, they clinical outcomes. The Centers for Disease Control and Prevention, the CDC, has described several broad categories of social determinants of health, including healthcare access and quality, education access and quality, social and community context, economic stability, and as well as neighborhood and built environments. Today, as we progress in our leadership series, we will be discussing some of the specific programs that are highlighted within our region hospitals, as well as our community, showcasing health improvement and overall community building. And these vital programs and services offered by our region's hospitals exist to help address non-medical factors with the goal of improving overall health and well-being for the residents here within Northeast Ohio. And so I'm pleased to welcome this lovely panel and group of experts to today's sessions. And joining me today, and I would just like for when I announce your names, just give a little wave, Karen Cook, the Director for Healthy Families and Thriving Communities at MetroHealth Institute for Hope. We've got Tom Olmstead, Director of External Affairs at St. Vincent Charity Medical Center. Jennifer Kinsley, Senior Attorney at the Legal Aid Society of Cleveland. And I've got Tina Stashevsky. Did I say that correctly?
Stashevsky.
Thank you. I was close. Vice President of Business Development at Ashtabula County Medical Center. And thank you all for being here today. And we're looking forward to hearing from each of you about your unique programs at each of your respected organizations. Before we begin, let me just add a quick reminder to the audience viewing this. Please post your questions within the Q&A box, and we'll have some time, hopefully, to answer some of those questions at the end. We're going to begin today with Tom as well as with Jennifer, and you both are here to talk with us today about the Community Advisory Board and the medical legal partnership between your respective organizations that helps patients resolve legal issues. So Tom, why don't you begin with telling us about the Community Advisory Board?
Brian, first, thank you for having me. I am pleased to be here. And since we do have a little bit of time, in addition to what we were originally going to use, I did want to talk just a bit about St. Vincent Charity Medical Center for those that are unaware of who we are, what we do, regardless of the fact that we've been here since 1865. So since then, St. Vincent Charity Medical Center and the Sisters of Charity of St. Augustine have been dedicated to the healing ministry of Jesus, with a dedication to the poor, a deep respect for the dignity and value of all persons, and a commitment to continuing education. We are an adult acute care hospital with three key service lines: orthopedics, bariatrics, and certainly behavioral health, which includes both psychiatry and addiction medicine. We're located in the central neighborhood on East 22nd Street. 80% or so of our patients receive their care via government funding. About half are on Medicaid and half are on Medicare. So I was asked to speak about the formation of our community advisory board. And you would think, having been here for 150 plus years, that we would have a pretty good handle on the pulse of our community. And we do. We take care of our neighbors in our community every single day. But that doesn't mean that we can forget about continuing to build trust between our community and the hospital. So much has gone on that we're all aware of over the course of the last year. And that's in some ways exacerbated how people perceive not just St. Vincent Charity Medical Center, but hospitals in general, especially those patients of ours that are underprivileged. So in late 2019, we established the Community Advisory Board here at St. Vincent Charity. And we did not do that in a vacuum. We did it in partnership with grassroots organizations, residents, public officials, healthcare, education, safety. And the goal was not necessarily to form a community advisory board made up of people who are not, forgive the term, in the weeds, who are not on the street. We really wanted to be able to put together a group that could bring a real perspective on what people in our community face every single day. And then that would in turn give St. Vincent the opportunity to create programs and initiatives that would most effectively benefit the community. So what was the purpose when we formed and we refer to it as the CAB, by the way, so forgive me if I use that acronym often. The purpose of that was to create a direct link between the community and St. Vincent leadership. And that's been done by establishing really ongoing dialogue between the community as well as hospital representatives that are on the CAB. These members do represent the daily lives of what goes on in the community, but having representatives from the hospital also allows us to be able to share initiatives that we are undertaking with the community, I think more effectively than we've done in the past. There are a few key objectives that I established when we first put together the CAB. One was, and I mentioned this earlier, one was to build and strengthen the communication between St. Vincent and the community, and in particular, to build or rebuild trust, which is really, really critical, especially these days. An example of that is the COVID issue. Over the course of the summer and fall, people were reluctant to come to the hospital because of COVID. In some ways, that reflects trust as well. So trust and building trust is a key objective for the CAB. It's also intended to inform our efforts as a hospital to be more impactful to our residents, the businesses, and others in this community. And it's assisted us in, and will continue in, shaping St. Vincent's future as a care provider in the central neighborhood and in this community. And it also, as I mentioned a bit earlier, it really does help us inform our efforts as we move ahead to meet those needs. Collaboration on initiatives in support of the community, it has been a sort of an outgrowth of what we've done over the course of the last year. So collaborating as an institution with the community is one thing, but we were really fortunate. In some respects, it's sort of a silver lining with COVID. We were really fortunate that most members of the CAB were quite interested in doing something immediate. What could we do immediate? Because the Community Advisory Board is really a long-term effort to create relationships. But given COVID, what can we be doing right now? So this group has been instrumental in providing PPE to the community to the tune of literally thousands and thousands of masks and other related materials like hand sanitizer, et cetera. So that's to the credit of this group, and it would not have been done if we hadn't put that cab together. Other really kind of interesting programs that I've seen over the course of literally the last few weeks. There are community health workers that are members of our CAB that are out in the community, and believe it or not, they don't have clinical backgrounds, but they see things every single day. So what we've done is we've tried to figure out how we can connect those people with our clinicians and provide essentially, call it Healthcare 101. So that when these folks are out in the community and they see someone presenting with a diabetic foot or some other issue, they're able to spot that. And because of that, they can communicate that information, not just to those folks, but they can also communicate that to us so that we can reach out and help those people. The size of the board is pretty significant. We have, and you'd think it would be unwieldy at this size, but we have about 50 members of the CAB. And as I said, they represent all walks of life in this community. In particular, I might add Phyllis Cleveland, who is our local city councilwoman and has been for almost 15 years and has been a dear friend of the hospital and the Sisters of St. Augustine. So I think Phyllis is probably the highest level person we have. But it's really critical that she be there because she knows this community well. She lives here and she's been a terrific advocate of ours. We meet once a quarter, but as I said earlier, there was an opportunity for us to meet more often and do something impactful immediately. And we did that. So we do have some subcommittees that address issues in particular. And I have a feeling, frankly, that this community advisory board is going to continue down those parallel paths where we want to strengthen the communications and the relationship long term, but we also want to figure out how as a group we can be more impactful immediately, as I mentioned earlier. That is essentially one of the initiatives that we've undertaken. Another is our medical legal partnership, and Jennifer is, as you can see, is here to talk about that.
Thanks, Tom. And I want to thank St. Vincent for ceding me some of their time to talk about our partnership today. I just want to start by giving a little bit of history of medical legal partnerships for anyone who is not familiar. The first modern medical legal partnership was started in 1993 in Boston, and this arose from the concept that a pediatrician was continuously giving the same patients prescriptions for their asthma and was seeing no improvement in their condition. And only when he discovered that the mold in their apartment building was exacerbating their symptoms did he realize he would need a lawyer to effectively treat the medical condition. And so that's how the first medical legal partnership came to be. Today, there's more than 450 throughout the United States and 49 states. And Ohio is home to 21 medical legal partnerships, 3 of which are partnerships with the Legal Aid Society of Cleveland and local hospitals. So we have our St. Vincent Charity Medical Center Medical Legal Partnership, which opened in October of 2017. And we also have MLPs with MetroHealth and with the University Hospital's Rainbow Center for Women and Children. So through these partnerships, essentially medical providers are trained by legal staff to identify health-harming legal needs that are affecting their patients. And then once the medical providers complete this training, they're able to make direct referrals that connect their patients to our legal team, who then work with the patient and, if necessary, the medical providers to address these health-harming legal needs to improve the health of patients. Some common examples are housing conditions, income supports, public benefits, family law issues, financial concerns, immigration concerns, and pretty much any other legal issue other than criminal law. Through this legal representation, patients then experience reductions in toxic stress. They report they're more able to pay for their medications because of income supports or assistance with accessing insurance. But they also have reported that they are more able to prioritize medical appointments, taking care of consistent, regular check-ins with their physicians, And they report that is due to job security. So they're no longer concerned that they're going to lose their job if they see their doctor, or we have secured safe housing for them, so they aren't worried about leaving shelter to seek medical care and that their belongings might get thrown away. So as I mentioned, our medical legal partnership started in October of 2017. That was through support of the Jones Day Foundation, the Mount Sinai Healthcare Foundation, the George Gunn Foundation, and PIGS Foundation. We've had several other funders since that time. And while the structure of our MLP has changed in that time, today it is comprised of myself, a senior attorney, and a paralegal. And since our launch, we have received 303 referrals from St. Vincent Charity Medical Center, which resulted in the opening of legal cases for 235 patients. But that number isn't a full capture of the influence and change that we're having in the community. So I would ask you to consider that in Q4 of 2020, 69 legal cases were opened at our medical legal partnership for 56 patients. But when those cases concluded, we were informed that 116 individuals were impacted by the outcome of those legal cases. So we're seeing more than double the effect that would be anticipated. What this means is that families and household members are benefiting from the increased income, housing stability, access to medical insurance, food benefits, education, and improved employability through record sealing of the St. Vincent patient. Approximately 70% of our patients were referred from inpatient units at St. Vincent. However, we also receive referrals from Rosary Hall, which is St. Vincent's Addiction Treatment Services Center, and from Joseph's Home, which is a sister ministry that provides medical respite care for unhoused males. The majority of these patients, well over 80%, report an annual income of less than $10,000 for their entire household. So that's a little bit about referrals. And once we receive the referral, the patient will be contacted by our paralegal to conduct a full legal checkup. And the goal of that conversation is to examine the legal health of every referred patient. So she will ask each patient questions about every area of the law and service that we can provide to determine how many cases need to be opened for that patient to increase their likelihood to access health. As I mentioned before, the only area that we cannot serve is criminal law. Once we open all of the legal cases, they either stay with me, get assigned to one of our other 64 attorneys at the Legal Aid Society of Cleveland, or one of our more than 200 volunteer attorneys who have offered pro bono services. Over the past almost 3 years, the #1 reason for referral to our medical legal partnership is for income supports, access to public benefits, food assistance, disability benefits, cash assistance. And most often, these are patients who are reporting they're seeing a reduction in benefits, a termination in benefits, or difficulty accessing the programs in the first place. As you can imagine, especially now, the second most common issue is related to housing, evictions, condition issues, and then we also see issues related to family law, child support, divorce, record sealing, bankruptcy, and public utilities issues. However, the medical legal partnership is not just affecting the referred patients and their families. We're also doing a lot of systemic advocacy through our partnership with St. Vincent Charity Medical Center. That includes trainings for local police departments relative to interactions with those with mental health diagnoses. We have identified and addressed systemic issues for sober living facilities, resources for the unhoused in the central neighborhood, and increasing access to meaningful communication with the Ohio Department of Job and Family Services for those with communication differences. But to be able to bring this to life, I wanted to share a few examples of what individual representation looks like through our partnership at St. Vincent. So in one case, our outcome was mandated bedbug treatment for the HUD housing unit of a cancer patient who had reported to the hospital with a bedbug infestation in his chemo port. So in addition to addressing the issue in his home, our social work department was also able to secure a new hospital-grade bed for that patient to return home to. We also restored utility service to a patient who was returning home from an amputation who had lived in a unit for several years without access to heat. We secured access to food assistance for a patient who reported to his primary care provider with a significant weight loss since his last appointment after food assistance had been terminated due to his inability to read notices because he was legally blind. We reduced a child support obligation to $0 for a diabetic patient who was unhoused based solely on his child support obligation for his currently 46-year-old child due to the amount that was being taken out of his disability check for child support. And finally, we sealed the criminal record from a period of substance use for a client of Rosary Hall who was only able to find work as a greeter during her period of recovery. After sealing her criminal record, she was hired by a local healthcare system to continue the work in the field in which she had earned and received a master's degree. So in addition to the training that we provide to providers, our systemic and direct advocacy, we do believe that we're improving the health of the community through St. Vincent Charity Medical Center. The changes that we make in one household can improve the lives of many and allow those patients to return to their community to utilize their benefits and access health care. We've also helped to keep families together and restore those that have been separated. We believe that improving the health of each member of the community improves the health of the community, and we're thrilled to provide this service with St. Vincent Charity Medical Center. Thank you.
We appreciate that. That was incredible. I mean, from a community perspective as well as extremely impactful. I am going to come back to you, Jennifer, in just a bit. I saw within the Q&A that the audience would love to hear about some of the other MLP relationships, but we'll take the questions at the end. But I just want to say, I think this is a great example just of collaboration. I think Cleveland leads from a healthcare standpoint because of our collaboration. And I think that's one of the biggest game changers in addressing COVID as well as helping our community. And you're leading that way. And I'm just really, really impressed. And I love the fact that you're building trust. You're focusing on these elements according to the CHNA that we all work together and develop for community health needs assessment. And I'm just eternally grateful. So thank you. We're now going to switch over to Karen. And have Karen with MetroHealth speak today about Unite Ohio. And this is a brand new initiative from what I hear, and I'd love for you to tell everybody about it.
Absolutely, and I appreciate the opportunity to join you on the webinar today and to share our story working with Unite Us and developing the Unite Ohio platform. First, I'd like to say just a quick word about the MetroHealth system. We are the public health system for Cuyahoga County, serving approximately 300,000 patients every year, and that care is delivered at more than 20 locations throughout the county. I'm here today representing our Institute for Hope. HOPE stands for Health, Opportunity, Partnership, and Empowerment. And the Institute was started in mid-2019 and represents the health system's commitment to act on the social determinants of health. So that is where the work that I'll be describing for you today finds its home within the MetroHealth system. So as Brian mentioned, the investment that I'd like to highlight today that addresses community health improvement is MetroHealth's launch of an electronic referral platform that aims to better connect and coordinate healthcare and social services. And there are a couple of key pieces of background that I would like to share with you that help undergird this work. And the first is that MetroHealth did make a commitment to screen our patients for social determinants of health. So that work kicked off in 2019. And our goal is to screen all adult patients. So as of today, we have 32,000 plus patients that have been screened for their health-related social needs. We recognize that it is not enough to just screen patients. We know that we need to find ways to respond and to find better ways to connect our patients to resources in the community that can help meet their needs. So simultaneous to this work is work that's grounded in our 2019 Community Health Needs Assessment. And I believe that document is attached as a resource for participants on this webinar. I'd like to highlight that that was a shared assessment. It was jointly conducted by multiple health systems, our 2 local health departments, and other stakeholder organizations in the community. And that is very important. That was the first time that such a wide-scale partnership had come together to conduct the assessment. So the assessment resulted in the identification of 5 priority areas, and also led to the identification of 2 strategies where the partners on the project would like to have some shared action. So one of these strategies was around addressing our desire to improve community conditions. And the strategy was to develop a multi-organization partnership to better link social service resources and community through both technology solutions and on-the-ground strategies. So this is really where our partnership with Unite Us is grounded in terms of our community health needs assessment and the accompanying implementation plans and strategies. So to underscore, the work I'm describing for you today is not just grounded in MetroHealth's interest in serving our patients and community, but really in that wider collaborative effort and that commitment to collective impact. So late 2019 and into early 2020, MetroHealth and our team at the Institute for Hope were actively involved in researching the many electronic referral platforms that are available in the marketplace. We participated in many product demos. We included a number of our partners who had a shared interest in this work in those demos. And we were fortunate that our local United Way and others convened a group of community-based organizations to provide feedback on, what their interests and desires would be for an electronic referral platform in our community. So we were moving forward at a good pace, and then we arrived at March 2020. And as we all know, COVID upended many, many things. And certainly in the healthcare landscape, that meant that, we really shifted our focus to things that became critically important at the time, and other things, ran in the background. So for a short moment, we did put our plans to choose and move forward to launch an electronic referral platform on hold. But I will say that was just temporary, because certainly what we quickly realized was, in the face of the pandemic, the people that we really knew we wanted and needed to serve were having needs that were just exacerbated by the pandemic. We also knew that a virtual platform took on new meaning in an environment where so much of our lives were being handled virtually. So we did decide to move forward, and I want to express gratitude to the commitment made by our CEO, Dr. Akram Boutros, for MetroHealth to make the investment in an e-referral platform and a creation of a network of social service organizations for the benefit of our patients and the wider community. So with that commitment, we did choose to work with the technology company Unite Us. We launched our planning work with them in June 2020, and then launched formally and publicly the referral network in late September 2020. And that network is referred to as Unite Ohio. So I'd like to say a little bit about why we chose Unite Us, but more to address a general question of what were we looking for in this type of a technology solution. One of the key things that we were looking for was a platform that would be free of charge to community-based organizations to participate. Unite Us provided us with that feature. We also wanted something that was fully transparent, so that users could see the full patient journey and work to avoid any duplication of effort. We also wanted something that had closed loop capability, so that anybody making a referral would receive an update in real time so that they could understand the status and the outcome of that referral. And we were also interested in something with robust reporting capabilities. Ultimately, we want to understand the impact of this work on the people that we serve. So what does an e-referral platform look like in action? Let's say a patient, Janet, is working with her care coordinator, Andre, at the MetroHealth system. In the course of service, Andre discovers that Janet has a number of social needs that cannot be met by MetroHealth. So Andre uses Unite Us to gain digital consent from Janet, and then he is able to make electronic referrals on her behalf to multiple community partners to meet needs that she may have, such as for food, housing, transportation, et cetera. Many of the things actually that were mentioned in the prior presentation and that are being addressed through medical legal partnerships. So through this platform, Andre can seamlessly communicate with other providers, and he can securely share Janet's information. As Janet connects with organizations and is able to receive that social care, Andre can then receive real-time updates and track Janet's total health journey. So we really have a fuller understanding of, one, Janet's needs, and two, how those are being met through a network of partners throughout our community. I'd really like to underscore that this tool is for community use. So any community-based organization that partners in this network can send and or receive referrals from any other organization within the network, regardless of any connection to MetroHealth. So it does not have to tie only to our patients or to referrals that are made or received by MetroHealth. So there is really wide applicability across our community for this. And I would like to also further note that the ability to make these direct electronic connections organization to organization takes the onus off of the individual in need to have to self-navigate to multiple service providers throughout our community. And that really, reduces some of what we might refer to as agency time, as individuals really spend lots of effort navigating to address their own needs throughout our community. So where are we at today after launching this platform in late September of 2020? Right now, there are close to 60 community-based organizations that have signed on and are participating in the Unite Ohio network. Over 1,000 referrals have been made to date on behalf of about 600 individuals. And we know that over 300 of those referrals have been successfully resolved, and hundreds more have been accepted, are in process of being served. I would just like to maybe wrap up my remarks today by noting that this work is really just beginning, as Brian also mentioned. So while MetroHealth was very pleased to be able to take this first big step to invest in and to launch Unite Ohio, we also know that other health systems are working through similar decisions, and we really look forward to them joining us in this effort. We also look forward to ongoing partnerships with our CHNA steering committee and their subcommittee that's monitoring the implementation of some of our shared strategies for action on our priorities. And ultimately, what our aim is to not move forward as one health system with community partners, but really move forward as a community that's working together and really providing opportunity for all.
I love that. I was finishing your last sentence. I don't know if you caught that.
Thank you.
I think every single one of us could say that, and that's what's really, really, really cool about our strategic relationship with everybody here and within this community. And I think it really sets us apart. I am absolutely floored though with the stats. I had not heard those statistics. And so I just want to compliment you, want to compliment Susan. I want to compliment Dr. B. I think that is a phenomenal return just right out of the gate. And so congratulations. And you're right. We got to get more folks involved and connected with that program. And then we also got some other programs we need to build and connect with that too. So I'm excited, Karen. So thank you.
Great, thank you. And thanks to all of our partners. That it wouldn't be a network without the 60 organizations that have made the commitment to join us. So we're grateful for them.
It's super, super cool. And that's the pathway for the future. This is all of us connecting. So really good to hear and see.
Thanks.
Hey Tina, I'm gonna have you now share some Ashtabula County Medical Center information regarding the Healthcare Access Navigator program that you guys lead and touch. Would you mind sharing that information with everybody here today?
Sure, no problem. Good afternoon. Thank you for taking time out of your day to learn about our Healthcare Access Navigator program. And thank you to the Center for Health Affairs for sponsoring this series and inviting us to be part of it. As Brian said, my name is Tina Staszewski. I am the Vice President of Business Development for Ashtabula County Medical Center. And in addition to my role of marketing, communications, and business development, I do oversee our community health needs assessment and our implementation strategy. A little bit about ACMC, which is much easier to say than Ashtabula County Medical Center, so that's how I will refer to us most of the time. We are the only full-service hospital in Ashtabula County, which is the largest geographic county in the state of Ohio. We are an affiliate of Cleveland Clinic, but we are still that independent, not-for-profit hospital. We have county in our name, but we are not a government hospital. So it's just a little bit about us. Our Healthcare Access Navigator program is still relatively new. So most of the information that I'm going to share with you today kind of sets the stage for why the program was needed. There's a lot of data points that I'm going to share, and the sources for those are a variety of local and national entities that, again, I'm not going to take up the time listing all of them, but anyone who is interested, I can share that offline or at the end of the presentation. I want to first have us take a look at a few key statistics about mental illness. 40% of patients in a primary care office have some mental illness. Approximately 67% of patients with behavioral health disorders do not receive the care that they need. 70% of youths in the juvenile justice system have at least one mental health condition. And then when we look at Ashtabula County adults, this information was taken from the 2019 Ashtabula County Community Health Assessment. 36% of Ashtabula County adults rated their mental health as not good for 4 or more days in the previous 30. 6% considered suicide in the previous year, and 15% felt hopeless, helpless, or sad daily for almost 2 or more consecutive weeks, and said that their symptoms interfered with their daily functioning. I think we all know or recognize that there is a strong connection between mental health and physical health. 68% of adults with mental health disorders also have comorbid chronic health conditions, and 29% of adults with chronic health conditions also have a mental health disorder. On average, people with severe mental health disorders die 10 to 25 years earlier than the general population. And a good portion of those deaths are actually due to the chronic health conditions that are manageable or even preventable with early intervention and routine follow-up in the primary care setting. There's also a connection between mental illness and substance use disorders. Let's consider the following statistics. 70% of Americans will suffer substance abuse in their lifetime. 18% of US adults with mental illness also have a substance use disorder. 50% of substance use disorders are co-occurring with additional medical health concerns. And when we look specifically at Ashtabula County adults, 74% in the survey that the county's health needs assessment report was based on identified themselves as being current drinkers. And 23% of those actually met the criteria to be considered a binge drinker. 7% use marijuana, 3% misuse prescription drugs, and another 3% used recreational drugs in the prior 6 months. Now, I want to kind of explore the role of primary care. Having a regular primary care provider allows the patient and provider to develop a closer relationship. The provider gets to know the patient, not just as a patient, not just as that condition being treated, but as a whole person. Treating physical health issues becomes much more challenging when there are also mental health or substance use issues involved. Poor self-care that is often associated with severe mental health disorders can lead to worse outcomes and even higher mortality. As the foundation of the healthcare system, primary care is well positioned to identify patients who may need intervention or treatment. At the same time, though, the convergence of physical health, mental health, and substance use disorders can overwhelm a primary care physician. Many feel that they're not prepared to develop a treatment plan specific to mental health or substance use. That's where an integrative or collaborative care model like our Healthcare Access Navigator can come in. It really brings together primary health and mental health to benefit the patient. A few of the things that model can produce: help ensure patients get the physical health care and the mental health care that they need, improve health outcomes, improve compliance with treatment plans, reduce overall healthcare costs, and allow for a cross-system team-based approach where each entity or each provider gets to focus on what they're good at. Turning specifically to Ashtabula County, the 2019 Ashtabula County Community Health Assessment identified access to care, chronic disease, mental health and substance use disorders, as well as social determinants of health as the primary needs in Ashtabula County. There are community resources that exist to address those needs, but many patients and providers don't know about them or they don't know how to access them. The Healthcare Access Navigator program is a tool to help overcome those obstacles. Our program is a collaborative effort between ACMC and the Community Counseling Center and is funded right now by a grant from the Mental Health Recovery Services Board. Our Healthcare Access Navigator has a bachelor's degree in social psychology, as well as experience in case management and social work. She is an employee of Community Counseling Center, so we have a signed business services agreement that allows us to share patient information back and forth. The goals and objectives of our program are to expand the identification of and screening for individuals with behavioral health disorders, to improve physical and behavioral health, to avoid hospital admissions and readmissions, to reduce emergency department utilization, reduce stigma, increase the awareness that there are comorbidities of physical health and mental health, and then enhance efficiency through same-day coordination of referrals and same-day access to intake and support, primarily done through telehealth. How do we do it? The Healthcare Access Navigator and the primary care provider sit down. They have an initial meeting where they develop their own referral relationship. They talk about how they're going to do the warm handoff and how they will develop a shared care plan for the patients. Screening is a key component to making a program like this work. A screening that identifies symptoms of depression or the extent of those symptoms that may classify it as a depressive disorder is embedded into the primary care visit. There is also a screening that may help identify if a patient has substance use or abuse issues. Our Healthcare Access Navigator is trained in SBIRT, which stands for Screening, Brief Intervention, and Referral to Treatment. She is also trained in motivational interviewing and trauma-informed care, and is qualified to provide CPST, which is Community Psychiatric Supports and Treatment. Combining some or all of those evidence-based screenings really does help ensure patients are referred to the most appropriate treatment option. Every good program needs outcomes to measure its success, and the things that we're measuring in this first year are the number of screenings completed, both on the primary care side and on the Access Navigator side, the number of completed referrals to primary care, to mental health, and to substance abuse treatment, and then the follow-ups. There's an immediate follow-up post-referral, then we want one at 6 months and another one at the 1 year mark to really keep that connection between the patient and the navigator to ensure that they're following through with that treatment plan. We began the program at the end of 2020 in one primary care office, and we're expanding that to a second office this month with the goal of having the collaboration available to all of our primary care providers by the end of the year. This really is a two-way collaboration. Our primary care providers identify patients who may need referral for mental health or substance abuse issues and treatment. But the Community Counseling Center staff are also identifying clients who don't have a primary care provider, and they have a process in place to refer that client to one of our PCPs. I think the other thing that I really want to point out is that this isn't just about the healthcare side of it. You know, we've talked about social determinants of health in each presentation. In the course of talking to our Access Navigator, if there is a determination that a housing issue or a food insecurity issue or employment issues, transportation issues are interfering with either the primary care side or the mental health substance abuse treatment side, that healthcare access navigator can also help connect the patient to those community resources. The program really optimizes community resources and effectively coordinates and integrates whole person care. It allows ACMC and Community Counseling Center to focus on what we're good at. At the same time, increasing collaboration to achieve objectives and improving outcomes without further taxing either of our entities' healthcare workforce. I don't have specifics to share with you because, again, the program really just got off the ground in December of 2020. You have holidays in there. We're still working on some other access issues with our electronic health record and that shared information process. But we're very excited about the program and are anxious to see what the results are. We're looking forward to a lot of success for our patients and for the community. So thank you for your time.
We're going to come back to you, I promise, and dig into some more of those results, I think, at a later session. I find it interesting in our Q&A that's happening right now is that folks actually want to start having another session around each one of your programs and possibly even some demos around some of the systems that were brought forward today, such as Unitas, which I think is a great idea. And I really want to applaud that individual for asking that question. And I think that we will definitely follow up and schedule some additional communications on this and sharing, throughout the world. I've got a couple of questions that popped up. Feel free to ask some more, but then I also have some questions from this end as well. And Tina, if you don't mind, since I already have you kind of captured,
Sure.
I would love for you to talk about your partnership with the Community Counseling Center, which meets such an important and commonly unmet need for patients. But as you mentioned, your Navigator system primarily supports primary care needs. Can you talk just a little bit more about those primary care specifics?
Sure. Ashtabula County is short of primary care providers. We're doing everything we can as a hospital system to increase that access. Some of that includes switching to care teams where we have specific primary care physicians working with nurse practitioners so that there is same-day access. They're a team caring for the patients. You don't have to see just one or the other because you're, let's say, Dr. Williams' patient. Dr. Williams and her nurse practitioner work together to co-manage the patient. So you're comfortable seeing the nurse practitioner on those routine follow-up visits. They're constantly talking about taking care of the patient together. We've opened primary care offices in almost every corner of the county so that access from a geographic perspective is easier. But still, you have individuals that don't know how to first get into a primary care setting. And that's where the collaboration with Community Counseling Center really helps. They have clients that they're already meeting their needs for either mental health or substance abuse issues, but they don't have a primary care provider who is watching their healthcare on a regular basis. And they're so interconnected that in some respects, neither side of that healthcare spectrum really improves to its greatest extent unless those two things are working together. So, collaborations with other community organizations that can identify individuals that don't have primary care and have a seamless referral process, I think really helps our community.
I love it. And I mean that. I've got a question that popped up, Tom, and it states the following. You mentioned the Community Advisory Board of the CAB that has been established to create programs to serve the community needs, and then mentioned a program during the current healthcare pandemic to distribute masks, et cetera. Can you provide an example of one or more programs the board has established other than just the COVID activities?
I thank you, Brian, for the question, or whomever asked it. A couple of things. To put it in context, we established the Community Advisory Board essentially in late 2019. We had our first meeting, and then we all know what happened. So from February until October or so, We were all just trying to make sense of, put one step in front of the other as we deal with this issue, both from a clinical perspective and a societal perspective. But I mentioned in my comments, I mentioned that we have now the ability to engage with community health providers, and most of the ones that we are working with live in this community and have spent their lives building relationships with people in this community. And what's interesting is that there was always this disconnect between sort of a clinical observation and then action and the more social engagement. More often than not, these folks are visiting the elderly. They're really dealing with more, I would say, mental health related issues. But clearly, and the data supports all of this, whether it's diabetes, obesity, heart disease, this community suffers at a disproportional rate in every respect, and you all know that. Though many of us have the same kinds of patients that we care for. So the idea of being able to literally take a physician, spend an hour, 45 minutes or so, in this case, through Zoom. And as I said earlier, helping these folks take their capabilities one step further by not just visiting folks and maybe bringing them food or whatever other resources might be of importance, but they're actually able to problem spot. And that's not been done before by many of these folks. So it to me, it does a lot of things. Those people that have been serving this community and living in this community for years, it's really important for them to be able to continue to grow and continue to share and continue to help. And this is one of the ways they can do that. And I can tell you the folks that participated in it were really excited. So our expectation is that we're going to expand this program so that we can help people identify where there are issues in the community specifically, and to be able to specifically engage and connect with those folks that perhaps in a way we didn't have before. So this gives us an opportunity to take care to the community, I think, one step further.
I appreciate that. Hey, Jennifer, quick question. Do you have any other advice for the hospitals besides UH? You mentioned Metro, of course, with Dr. Boudreaux's team, Karen and Susan Fuhrer. But who else out there, could partake within, this type of relationship from an MLP? What advice would you have for them, and how could they connect to you?
So I really think that MLPs are needed at every place where medicine is happening, just because it's a proven fact that social determinants of health are a barrier to not only access, but thriving. There is legislation floating around now through the Department of Veteran Affairs to allow for funding for medical legal partnerships. There already are VA MLPs, but not in Ohio. So I would say anywhere where medicine is happening, you should be looking into medical legal partnerships. There is an organization called the National Center for Medical Legal Partnerships. I would encourage interested individuals to review that website. Someone mentioned MetroHealth being one of the first. So that program was launched in 2003 and has operated continuously since that time. It is one of the pioneers. And so I would encourage interested individuals to reach out to some of our current partners to talk to them about how they feel about the program. I would encourage people to review the toolkit for how to start a medical legal partnership that's available on the National Center's website. But I would say the best source of knowledge is our knowledge, institutional knowledge at the Legal Aid Society of Cleveland. We have a lot of the contacts that started the first MLP. Our managing attorney, Katie Feldman, oversees the relationship building along with Melanie Shakirian from our development department. if people are interested or want to make connections, I would suggest reaching out to us. You can reach out to me or contact the Legal Aid Society of Cleveland to set up a conversation to see if this might be a good fit for you.
Thank you. Karen, you know I'm going to ask you some more questions, don't you, about Unitas?
I'm ready.
And have you seen the thread?
Yeah, I'd like to.
So either you're paying off some people, or they are super excited about learning more about this. And as I said, I promise each of you the opportunity to do a follow-up program just around your specific endeavor, and we'll definitely enable that to actually happen for you. But quick question, which everyone's asking on this thread: how can other non-for-profits, community-based organizations, as well as the hospitals, link directly up to you and your team?
Yes, absolutely. So in terms of the question as to whether other hospital systems can join Unite Ohio, absolutely yes. And for that, I would direct you to the Unite Us team directly. I'm happy to follow up with some contact information if you'd like to reach out to me at kcook, KCOOK, at metrohealth.org. You can also go to ohio.uniteus.com, and there's a button there to learn more and become a partner. So for health system partners, it would look more like a contracted relationship and a sponsoring relationship. So that would be handled differently than a community-based social service organization. But I will say for health systems, this is a tool where you can embed a launch point directly into your EHR. We happen to use Epic, but it's EHR agnostic. So it makes for incredible ease of use for our staff in terms of linking to this resource. For community-based organizations interested in joining, please reach out to me directly. We would be more than happy to work to set up a demo of the tool and to really walk you through what some of those options are and welcome you into the network. I also saw a question about any gaps. So right now we have organizations that cover all of the 20 major service types within the Unite Ohio tool. But I will say there are certain needs that are really acute in our community and that we are looking to actively recruit more partners. Chief among those would be housing and transportation. And I think there was one more question about the name Unite Ohio and whether that signals potential statewide approach. And I do know that the Unite Us team is working with other communities throughout the state to develop similar components to the network. So yes, but I will say that MetroHealth and Cuyahoga County's network were the first in Ohio and really got the ball rolling.
But we appreciate them. We appreciate everyone today in participating, and a big thank you to Tom, to Jennifer, to Karen, to Tina. And it literally brings kind of an end to our session. But I want to thank you as well as all the attendees for joining. I want to say that you all illustrated really well, the many different ways in which hospitals can offer services to uplift the community as well as address social determinants overall. And we're very, very appreciative of that. The third installment, just for the audience sake here, associated with our hospital community benefit webinar series, is scheduled for Friday, March the 12th. And I just asked for clarification of that if you saw me writing some things down here a minute ago. And we'll be addressing a different facet of community health benefit, and that's going to be research as well as health professional education. And in this third installment, our hospital community benefit webinar series, the Center for Health Affairs' own population health leader, Patricia Terstenak, will be joined by speakers from Cleveland Clinic, University Hospital, Southwest Medical Center. And so I want to say thank you again to everybody. I hope you'll join us again. And like I said, if you didn't see the other ones, go ahead and go on to those and take part within them. Until then, until our next series, remain safe, keep that mask on. And everybody here wants you to, so you go do that. All right. You take care, and thank you all. Really appreciate
Thanks,
it.
you.
everybody.
Bye.
Bye-bye.